Hello, ladies and gentlemen. I am O'Brien McMahon, and this is People Business. In this episode, I am joined by Matt Jarvis. Matt is a Senior Vice President of Strategy with Lockton's pharmacy practice, where he partners with employers and health plans to design and manage pharmacy benefits that reduce waste, improve health outcomes, and enhance the member experience. With over a dozen years of experience across pharmacy benefit management, specialty and retail pharmacy operations, and clinical program development, Matt brings a deep understanding of pharmacy market practice, supply chain dynamics, and the factors that influence consumer medication access. Matt is a PharmD who has served as a pharmacist in a retail pharmacy, and he now works with Lockton, where I work, to help our clients better manage their pharmacy spend. And that is everything from how they contract with the PBMs that are out there, how they understand the pharmacy landscape, how they manage and track the guarantees in those contracts, and then deep dive into different diagnoses and claims and utilization patterns and all kinds of things related to pharmacy. This is a very, very complex topic. As soon as you start getting into pharmacy and drug pricing and drug contracting, all these terms get thrown out, all these acronyms, it gets very confusing and most people just kind of glaze over. But pharmacy is increasing at a trend higher than medical trend right now. And we all know that medical trend is increasing out of control. And the world is only getting more complex. But it is also moving in a positive direction and getting more transparent. There are more options for employers and health plans out there. And so I thought it would be a great time to bring Matt on the show and dive deep into, admittedly, a niche episode, but one that could save employers and their health plans a lot of money over the years as we move forward. So I'm excited to share this, just like I've done with other really niche topics. This is one where we start in the shallow end and kind of move gradually into the deep end, although it gets deep pretty quick. So bear with us. If you know pharmacy, the first couple minutes, we're defining terms and we're kind of getting into it, but we do get into some more complex strategies and what are the things that really move the needle when it comes to cost? What are the things that really move the needle when it comes to clinical outcomes? And how can you be purchasing pharmacy in the best possible way for your plan or your organization? Hope you enjoy it. Here is Matt Jarvis. Matt, welcome to the show. I cover a lot of broad topics on this one, but we're going to get super niche and get into the world of pharmacy. And this is good because even though I do this for a living, this is very complex and I'm going to learn a lot today. So welcome to the show.
Yeah, looking forward to it. I think the one thing in pharmacy is we know it's going to change tomorrow. So let's dig in.
I've done a couple of these where we've gone niche on rewards topics or other topics, but I think it's good. Let's start at the surface, maybe in the kiddie pool, and then we'll wade into the deep end by the end of this. Thinking about health plans, because I was prepping for this, I wrote this question down and I was almost like, is this just too dumb of a question? But let's start here and we'll see. We think about buying health insurance and we just think about, oh, we have our health plan. Like this is the health plan. But under the hood, the pharmacy and the medical plan are actually two different things. Can you talk about the setup of the pharmacy plan and maybe any misconceptions that people have about how it operates versus how the medical plan operates?
Yeah, I think, and there's probably a couple buckets that we put that in. I think at the super high level, we start to talk about unit cost economics in pharmacy. And a lot of times that's the classic, what's the discount that I'm getting from my PBM? What's the rebate that I'm getting on the back end? And I think that's a big component. And I think historically, that's how we've looked at the pharmacy benefits, like how good of a unit cost can I really ascertain from either the PBM I'm working with or the pharmacy that I'm working with, if you might be a hospital health system. But I think underneath that, there's a lot of things that happen when we think of that transaction. There's a huge supply chain. So you think of drug manufacturers that are setting price, they work with wholesalers. And then you also see pharmacies that are taking a bite, PBMs, depending on how they're making revenue. So you start to see along the chain, like a lot of cuts being made in terms of where the price started and where it ended up when we think of the employers. But I think when we think of unit cost, that's always been this thing is like, how can I get a better price? And I think where the market's starting to go is they're starting to say, yeah, I want a really good price. But if you get that good price and utilization is just uncontrolled, is it really helping me long term? And so I think it's starting to transition into more of, yes, unit cost is a piece, but this concept of drug mix management and how formularies are delivered and why can't I get someone on this drug versus this drug? It starts to make that complexity, which I'm sure we'll get into today.
All right. Well, I feel like we jumped in a little deep water. I'm gonna back you up a little bit.
Perfect.
We're gonna get into all that and unpack all of that. But you mentioned the term PBM, and I always want to make sure that we're defining acronyms because especially when it comes to the world you and I live in, there's a lot of acronyms. So, what is a PBM, and why does it even exist in the first place?
Yeah, so we'll start there. And again, we love acronyms. So pharmacy benefit manager. And I think we've seen that really evolve over the last 10 years, 15 years. But if you go back to like when they started, the whole thought process for a PBM was who is going to adjudicate these claims that are going through pharmacies and helping an employer essentially just pay those claims. So they really were just a claims adjudicator. And obviously, as pharmacy grew from 5% of overall healthcare to where it is today, where it's 35, 40% of every dollar that an employer spends, they have brought on a lot more responsibility. So obviously, they have size. And so they're like, hey, if we have size and scale, like we really should go back to these manufacturers and start to really negotiate them better. And so, how could we do that? So, we have this concept of creating formularies that prioritize one drug over another so that they can get better rebates from the manufacturer. That really exploded. And then they started to say we could start to charge for all these additional fees. And then what if we really owned our own mail order pharmacy? What if we owned our own specialty pharmacy? We could additionally make more profit within those things. And so what started in a claims adjudicator became these behemoths that had every aspect of the supply chain. And if you fast forward to today, they are adjudicating claims, they are filling scripts, they are actually some of them actually have their own drug manufacturer. So they're actually developing the drugs that are on their formulary. So it's become this essentially black box of different revenue strategies, but it all started with I just needed someone to adjudicate my pharmacy claims at the pharmacy.
And why? I don't know how much history you have on this going back decades, but like, why was that created in the first place? Why couldn't it just be done through the regular health plan?
I think that's a good point. I think it was because, and this is just my thoughts here and opinion, I think there were so few claims at one point, and they were like, these claims really don't cost anything. And so I almost feel like it's one of those where like the medical carrier was like, it's not worth our time. And then you had a couple of kind of TPA like guys that were like, we could start doing this. And I'm sure they owned pharmacies and they're like, we can start doing this. This is a service that we can provide employers. So now you can offer a pharmacy benefit. We'll adjudicate the claim. We'll invoice you. This is another layer of your benefit. And then obviously it exploded from there.
Yeah. So let's talk about the other layers in this because you started to unpack this. You think about the drug manufacturers, the Pfizers of the world. Why aren't they just selling directly to the health plans? What is the step? What are the steps from I make a drug to somebody shows up at the pharmacy and buys a drug?
Yep. And I think a lot of that comes to as PBMs got size and scale, right? They all of a sudden, and today they manage hundreds of millions of lives in the US. And so, from a manufacturer's perspective, if I'm bringing a drug to market, it was all around market access. So, like, how do I get access to the largest group of the population so that I can sell the most product? And so, where PBMs created this niche is I have 100 million lives. So, Pfizer, when you come out with this drug, how aggressive can you be on pricing? And we're talking about rebates. How many rebates, how much rebate dollars can you give to me, the PBM, so that I will put your drug at what we would call preferred pricing? So, that tier two formulary where the most people have access, we have limited prior authorization, whatever it is. But essentially, that allows Pfizer to say, I'm going to get the best access if I put all of my rebate dollars with an Express Scripts or a UHC or whatever it may be. But a lot of it just came to like, how do I sell as much product as I can? And PBMs had the life count that the manufacturers want. And that's created this whole back and forth that we see between negotiating rebates and the concept of formularies that are less focused on actual outcomes and more focused on financials with the rebate game.
So let's talk about formularies because you've mentioned that a couple times. I feel like most of this is going to be like, let's just define terms for people because
Sure.
this can be so complex. I guess define what a formulary is first, and then how does a formulary get put together?
Yeah. So simply put, just think of it as your preferred drug list. So every PBM is going to have multiple layers, like multiple formularies that they offer. A lot of those kind of, if we go into how they're developed, are negotiated based on rebate value. So some of your formularies are going to have less products, but more focused opportunity on certain drugs, which have the highest rebates. So those are going to be more your rebate driven formularies. And then you're going to have some formularies where it's what we would call open access. So there's really nothing excluded. All products are accessible. And so as you limit access or grow access, the rebate value either grows or changes. And so if you think about how formularies develop, it is heavily focused on those conversations between a drug manufacturer and a formulary. And all of it comes down to is dollars.
So thinking about this on the medical side, you have in and out of network providers, right? And so if you have Blue Cross Blue Shield or United Healthcare or Cigna or Aetna, they have gone out, they have contracted with doctors, hospitals, and there are certain ones that are in network and there are certain ones that are out of network. And most plans, you can go out of network, but you're going to pay more. Some plans you can't go out of network at all. The plan won't pay anything. And that is that the best analogy to think of with the formulary too, is it's like it's telling you what drugs are in or out of network and whether you can even go in or out of network.
Yeah, very similar. And that would be like the open formulary would be everyone can get basically any drug they want. Or if you have what's called a closed or a managed formulary, yeah, there's some drugs that are available here. But if you want something that's not on the list, plan's not paying for it. It's full out of pocket cost for the member. But exact same example.
So this is the first place where we get into, ooh, this might not feel good, where what I hear you saying is that these formularies are largely put together based on the rebates they can generate or based on the pricing that they can get, not based on anything. I have yet to hear you say clinical outcomes. So
We all want that. We all want to be like, oh, this formulary is going to drive to the best drug. And it's just, that's not how they've been developed today. Now, future state, we may see that change with what's happening, but you're dead on.
does that not exist anywhere? I know we'll talk a little bit about the evolution of PBMs and some of the new vendors that are emerging and how they're doing things different. But is there nothing out there that's just clinical based formulary?
There's several PBMs in the market. They're not going to be the large ones that everyone's heard of, but we do have some that are very strategically focused on clinical management. And I think the catch 22 in that conversation is when we say detailed clinical management, that comes with a layer of additional management for members, which sometimes we hear the word disruption, or I can't get my drug in 2 days, it's going to be 4 days, or I told my doctor no because he actually prescribed the right thing. And so I think that's the next conversation is like we have to redefine what disruption is before we can truly get to a clinically managed formulary.
Yeah. So let's talk about doctors here too. I think this is another point where you're like, oh, how does this work? So doctors are out there prescribing medications, but that doesn't mean that it's necessarily covered by your plan. So what are the role as you see it? Why is there a disconnect between doctors and the plan designs and formularies, and like what do doctors do well and maybe what do they not do well when it comes to pharmacy, and then what does the formulary do well or not do well? What are the pros and cons of each step and the role that they play?
Yeah, I think that if you start somewhere, you think of just go look at a formulary, like a preferred drug list. If you go look one up online, it's probably 200 pages of PDF. So provider's not going to look through it. A member has no idea how to navigate it. So that's one con with the formularies today. They're just too massive, too detailed. It is literally a PDF list of drugs. I think on the provider side, most of these are going to be specialists. And so a provider is not going to have a repertoire of 100 drugs that he prescribes. Typically, they're going to have 20 drugs that he knows in and out clinically. What is it indicated for? What is it not indicated for? Those types of things. And so he's going to have 20 drugs that he is always going to. Problem is, he doesn't know for the member that's in his office for today, who's your PBM, who's your employer, which formulary with that PBM are you on? So that's always been a gap. And I think you're starting to see some things within the EMR that are looking to help providers with that. But I think the other gap is providers more than anyone have no understanding of what the price of drugs are. When if you went to any provider and like, hey, did you know that this drug cost $100,000? Their eyes would be wide open. I had no clue that was it. And that's another issue that we have from just the non-transparency in the environment.
Can you talk about drug reps and what their role is in this whole thing?
Yeah, I think the direct-to-consumer advertising has always been an issue. It's funny when you talk to anyone, you can usually name the top 5 drugs in the US just based on what they've seen on TV. And most of people can actually sing the song that was in the commercial, which is sad, but that's where we live. 'Cause I think on the other side of that, outside of a manufacturer wanting to create access by giving rebates to get on a formulary with one of the large PBMs, but I think on the flip side, they also have a sales team. So they are going into providers' offices, educating them on why this drug is the best drug, those types of things. And so that is another place I would say where providers can be influenced. They can be influenced by clinical trial data that is very difficult to understand. Just statistical significance in some of those clinical trials is very hard for most providers to understand. And so, really knowing if a drug from an outcomes perspective is the right drug outside of what the sales rep is telling them can be very difficult, but it's definitely an influence that we see impact providers for sure.
I feel like there are two ways to look at this. There's the generous way and there's the cynical way, right? The generous way is that drug manufacturers are out there doing R&D and they're coming up with these great drugs that are saving people's lives, and in order to create awareness, they have to put a sales team out there to educate doctors, and the doctors are so busy that they don't have a lot of time, and so they are just trying to get whatever education they can. If they find something that works, they're going to stick with that thing, and they don't have the bandwidth to really understand the full market because it is just so complex out there. And that the PBMs are trying to put together a list to help employers save money, and so they're putting these formularies together as best they can. Then there's the cynical take, which is these drug companies are trying to make as much money, and they don't necessarily care about whether they're the best or not. As long as it works a little bit, they want everybody to be taking their drugs. So they march their salespeople out there. There are doctors out there who will take all the whining and dining that they can. And the more they sell, the more they get wined and dined. So they like that. So they push those drugs. If there's any indication that it might work, that's where they're going to start. Doesn't matter what the cost is. And then on and on we go. And I feel like there's probably some of the first, and there's probably a lot of the second, and like it's probably all out there in the market.
Somewhere in the middle for sure. I think majority of providers are trying to do the right thing. I think PBMs, based on how the market has been set up, are trying to negotiate as best they can around getting the lowest net cost. Now, they've built structures that make it very difficult to understand that, and why you might offshore your rebate aggregator becomes some questionable stuff that it drives some additional cynicalism there, I think. But I think it's definitely somewhere in the middle. And
Yeah.
unfortunately, I think this is where you find employers trying to navigate this, and navigate cost is somewhere in the middle between what the providers are wanting to deliver their plan participants, but also how they're negotiating and really trying to hone in their healthcare costs.
Yeah. And I think whether you take the cynical approach or whether you give them the benefit of the doubt, like the outcome is the same, which is you really got to pay attention to this stuff and keep iterating on it to make it better and better as the market is moving in a better direction.
Yeah,
Ultimately, it doesn't matter which one's happening. The outcome is the same.
yeah, as long as you're not setting it and forgetting it, it's definitely something that you have to continue to iterate on, I would say multiple times a year. It's changing so phenomenally right now. Even on the rebate side, I think even within the number of PBMs in the market, I think it's north of 80 today. And then you also see everything from a regulatory space, both at the federal and state level, that are really driving a lot of change. And so I think what we're seeing this year is going to look different next year. And then when we get into 28 and beyond, it's going to be even larger.
Do you see AI having a role yet in how doctors are prescribing medications? Because it would seem to me like they can only manage so many in their head and really get to know them. But with some of the tools that are available now, they might be able to be more strategic around what they are prescribing. Are you seeing that at all on a population basis?
I've not seen that particularly for providers, but I do have to think there's definitely some benefit there when we think of helping them really navigate some of the kind of clinical trial data. I think there's definitely an opportunity there with an AI. If I'm a provider and I am a specialist doing something and there's a new drug on the market, like I can actually use AI to help me really understand some of the key differences very quickly instead of looking at hundreds and hundreds of pages of documents. I think there's definitely an opportunity. I don't know if we've seen that just yet. I think there's definitely some reservations. I think on the PBM side, we've really seen AI start to focus on that member experience and service levels. And we may see that transition into more of the clinical piece over time.
The last sort of part of the system that I want to talk about is the actual pharmacist. What role does the pharmacist play in our current system today?
Yeah. Yeah. So I think there's multiple roles. So I know obviously we talked about at the PBM level, right? And if you're a plan sponsor, you're doing things around step therapy and quantity limits. And one of the bigger things we see is prior authorization. So from the PBM side, we see pharmacists really looking at those prior authorizations when a provider is writing for a high cost script and we're saying, hey, we're going to pause. Is this the right diagnosis? Have they tried alternative drugs? Do we have the right lab values? Are we documenting the chart notes? And pharmacists really playing a role there to say, yes or no and going back with providers on the control side. And then I think pharmacists actually at the point of sale is where you see that network access side for members saying, okay, I've gone through the PBM, I'm going to pick up my script, whether it's CVS, Walgreens, whatever. Then it's a full dispensing side. And so I think there's additional clinical strategies we're starting to see really at the pharmacy level when we get into that dispensing role. And I think that's where we're also seeing a lot of change. I think you're seeing a lot of changes within the retail environment. A lot of retail pharmacies are closing because of reimbursement. And so it's bringing back this conversation of are we starting to see more pharmacies online, like with Mark Cuban, what Mark Cuban's doing, Amazon definitely trying to play in this space. And so I think access is going to change as retail pharmacies mold, but I think we're going to see a different dispensing model hopefully in the future. But a lot of that is tied to just reimbursement changes.
And is there any ability at the pharmacist level? Because the pharmacists should be experts in more of these drugs. Are they able to have interventions, or are they helping patients move through, navigate the formulary better? Or are they really just dispensing whatever is prescribed at this point? And that's kind of
Yeah, and it could probably do a better job at it really defining dispensing. So within that dispensing, if someone's getting a drug, we're not just literally counting by fives and letting it go out the door. So there's a lot of clinical checks. They're looking for drug interactions. How does this dose look? Is this an overdose? Is this an underdose? So things like that are everyday occurrences there. I think the thing we are starting to see, and we have a few states, and this is typically at the state level, where you do have a few states like Florida and California that are allowing pharmacists to prescribe more in some key disease states. So, treating things like the common cold or working with patients around different blood thinner strategies. So, there's a small list in certain states where actually pharmacists can be more of that provider focus, really because they're going to have better access. But also, to your point, like they understand those drugs. So, there are key disease states where maybe you don't need to go set it off and sit with a provider and you can go into your local pharmacy and they can prescribe you something for a sinus infection or something topical for a fungal infection, something like that. And I think that's an interesting area that we probably will see grow over time just because of what's happening with obviously providers, but also just the changes that we're seeing on the reimbursement side. You're going to see pharmacists hopefully take a better role outside of dispensing.
Yeah, interesting. Interesting. All right, so we've laid out the pieces in the machine here between the manufacturer and the PBM, the provider, the pharmacist, and the employer actually sponsoring the plan. You started to go there, so let's go there. There are utilization management programs that companies are putting in place. You mentioned prior authorization, step therapy, quantity limits. Let's just walk through and unpack what those are and the pros and cons of those. Prior authorization has been in the news a lot lately on the medical side, and carriers really cutting back on prior authorization requirements. What are we seeing on the pharmacy side? What is prior authorization? How effective or ineffective is it? And how much is it based on clinical outcomes versus financial outcomes?
Yeah, no, I think prioritization is key. And it's nothing new on the pharmacy side, but at a very high level, think of any drug that we would deem maybe high cost. And so this could be a branded drug, it could be a GLP-1. A lot of times this is every specialty drug, but as the doctor writes that script and it goes to be processed through the insurance, it's going to stop at the pharmacy and it's going to say prior authorization required. And really all that means is the PBM is putting something in place to go back to that provider and say, one, do we have the right diagnosis for this drug? If it's for a diabetic, do they have a type 2 diabetic diagnosis? But also, this drug may have lower cost alternatives. So, what has this patient tried that maybe didn't work, or they had a side effect to something like that? Or this drug could have some other requirements around lab values that need to be checked, or other comorbid conditions they need to have to meet these indications. So it's really a stopgap for a PBM to say, hey, before an employer pays for this drug, let's make sure we've got everything in order so that we're not spending money on a drug that maybe is not driving outcomes. Now, I say that, and I think your other question was like, was it financially motivated? Is it clinically motivated? there's things you have to think about because most PBMs charge for prior authorization. So it could be $50 for every prior authorization. If I got a
Mm.
10,000 life group, those can stack up over time. And so then it becomes, if this drug costs $200, is it worth me as a plan sponsor to put the stop in place, disrupt the member, and get charged $50, especially if all the prior authorizations 90% of the time get approved. And that's the place that we're having a lot of conversations around prior authorization management. And I think what we've seen a little bit is if you have a PBM where maybe they have more of the dispensing assets or the fulfillment, a lot of times we see higher approval rates. So as you're an employer plan sponsor, you're saying, is prior authorization really working if 90% of the time it gets approved? And so we start to look at, okay, is it being effective? If they're denying a bunch of, like, on the flip side, we have some groups where we look at their prior authorization rates and it's a 60% approval rate. We're like, that's actually really good. We're not hearing member noise. Okay, that's great. It's a 60% approval rate, but what's happening on that 40% denial? Are they all just going to appeal and getting approved anyway? Or are they actually holding true? And so that's another level of detail where we can start to say, if you're holding a PA approval rate at 60% and you're not getting a lot of things approved on appeal, then I would argue your clinical criteria is working and the providers are agreeing with it, provided we're not getting a ton of noise. But the concept that we see within prior authorization and how I think groups should start to look at it.
Are you seeing groups just washing their hands of it and saying, you know what, if 90% of this is being approved, let's just take this out of here?
I would say that's not widespread. We do have groups from time to time. They're like, we're just not even going to mess with prior authorization. I will say a lot of times those groups do have higher per member per month costs. And I think that probably has changed a little bit with the last 2 years of GLP-1s, just because of how impactful those have been from a utilization perspective. But I think too, the thing we'll probably never see is when we get into some of those specialty drugs. So think of like super high cost drugs, oncology, we're talking hundreds of thousands of dollars in claims. It's very advantageous to say, hey, we're going to spend time for 4 or 5 days, make sure we've got the right drug here before we're shelling out those kinds of dollars. I don't think you'll ever see that go away on the specialty side,
Yeah.
but definitely on the non-specialty, we have some groups that are like, hey, is the juice worth the squeeze? Those types of things. And that's where you really want to dig into the data to say, okay, what's really happening here? Does it make sense? What are we being charged? And I think we've had some groups start to look at it more at a drug class level. Okay, what are we paying on average for these scripts? And okay, does it make sense for us to have a PA here if the highest cost drug in this class costs $100? Like, why are we even doing this? And so I think that's a different conversation, but that's definitely growing.
And you've mentioned specialty drugs a couple times. Do you want to just talk to what the different drug tiers are and what qualifies a drug to be in any one of those tiers?
Yeah, so to super high level, we typically tier out drugs into formulary. And so think of tier one as those cheapest, lowest cost generics. Tier two being those brand drugs. Sometimes you hear that called preferred brands. So those are the drugs we talked about earlier where they're probably giving the highest rebate dollars to the PBM for that tier two placement. Tier three is what we typically call non-preferred brands. And if you think back to an employer's plan design, typically you're going to have a lower cost for tier one. Tier two is going to be that secondary cost. Tier three is going to be a little higher. And that's just to help drive members to the lowest tier, which should be the lowest cost for the employer. And I think of tier four as those specialty drugs. And if we get back to the cynicalism that we were talking about earlier, everyone's like, what is a specialty drug? It really depends on the PBM you're working with. You can think of high cost drugs, might have some storage requirements, might have some additional clinical edits, but the specialty drug definition literally differs by PBM. And that's something that's very difficult in the market. You have one that says it is specialty and one that isn't. And that's where there's a little bit of gray area.
Yeah, that's frustrating. Do the specialty pharmacies have any kind of similar definition that they're using?
No, a lot of times there's a little, that's a good question. I think even within the specialty space, like typically they're contracted with a PBM for network, right? They want to be a part of the network, even if they're a specialty drug. And so it's still going to depend on that PBM. There's a little bit of leeway within the specialty space. You have some drugs that you might consider like orphan drugs or what we call limited distribution drugs, where that specialty pharmacy is actually contracted with the manufacturer to be the only dispensing pharmacy. And so that's where it's a little different, where a specialty pharmacy can get a little more market share outside of the PBM. But outside of that, it typically still comes down to the PBM and their network strategy.
And then from the brand, the preferred brand and the non-preferred brand, that's just we're getting more rebates, and so we'll make that preferred versus we're not getting the rebates, so we'll make it
Yep.
non-preferred. Like that's not a quality of the drug necessarily. That's just
Not
a
necessarily.
where we can drive lower pricing.
Typically, yeah. And you think of like classes like diabetes, and you can use GLP-1s. There's 6 or 7 different GLP-1s out there for type 2 diabetes, and you're going to see everything we've heard of today, like the Mounjaros and the Ozempics. Those are going to be tier 2. The Trulicities, the Byettas, things that most people haven't heard of, those are typically tier 3.
Yeah, because they're not putting as much money behind them.
Exactly.
Yeah. Wild. We talked about prior authorization. Let's get back to that. What is the difference between that and step therapy?
Yeah, so step therapy is something that we see advantageous in a lot of those drug classes where you may have a lot of alternatives. So think of, we can use diabetes, for example, we can use blood pressure, but any drug class where there may be 8, 9, 10 different drugs that work the same way, but let's say there's some that are generic, some that are brand. So plans will implement a step therapy to say, hey, anyone that gets a script written for one of these brands, we're going to put a step in place to say, hey, for you to get access to that drug, you have to try 2 generics that work the same way. And so it's a simple way. I would say, like, we make pharmacy so complex. At the end of the day, you're trying to get to generics as fast as possible. And so think of it as one of those strategies to say, hey, how are we making sure that people are prioritizing a generic if there's a brand available, just so that we are doing the due diligence to make sure that we are getting the lowest cost. And so a simple step therapy is just to say, you got to try and fail these 2 drugs or these 3 drugs before we'll let you step into a higher cost product.
And I think this is where there's some confusion too. If there's a generic available, why wouldn't we just force everybody to take the generic? What is the difference in the actual drug between a generic and a brand, or even between 2 generics? Because you can have somebody have a side effect to one or the other, but they should be the same drug. So why are they the same drug, and why are they not the same drug?
Yeah. And so it's a good question. And I when I worked in pharmacies, like, this was like what I did all day, every day. But obviously we have drugs that come to market. They have patent life. They're a brand for a very long time. And if you think back to the last decade, we saw the Lipitors that went generic, and it was this huge deal. And so one of the things that happens when that patent life goes away, obviously more generic manufacturers can start making those drugs. And so it always brings up a conversation of, like, I had success in the brand. Is that going to continue if I go to the generic? And so when we think of the generic, it is the exact same chemical that is in the brand. What can be different, though, is some of the inactive ingredients. So think of like the fillers or the dyes. But at the end of the day, and they call it AV rated generics. And basically that just means if a generic drug is on the market, the pharmacy or the provider can switch that drug no matter what safely, because the FDA, within it being an AV rated generic, basically says that it has 90% of the efficacy as the brand product. And they say that 10% should have no effect on outcome or efficacy at all. And so that's the chemical difference. But then you start to think of some people, they may have an allergy to a filler or something in that, or there may be a dye. And again, that is less than 0.111% of people. But those are some of the differences, but a very high level of generic is guaranteed by the FDA to have 90% efficacy, which should not impact the actual outcomes of the drug. And so that's why if you're on the pharmacy side, we're like, generics are great. There's no problem. I would always recommend generic, but there's always the small nuance in the population that may have an issue. So you have to think about that.
And it makes me think of placebos too, because like I've heard the studies where you give somebody a drug and you give somebody a sugar pill, but you tell them it's the drug and they have the same
Yep.
outcomes, right? Like they get
Oh, yeah.
better, which is blows your mind. So I feel like there is a group of people out there who, and I'm not disparaging this group, but they're like, brand is better. This is the drug I was prescribed. This is the one my doctor wants. I'm going to be skeptical of these other drugs, and therefore I'm going to believe that they don't work. And therefore, whether they are working or maybe they don't work then because I just believe they don't work, or maybe I'm extra sensitive to side effects or to anything that be perceived as a side effect just because I believe they don't work. Is there, other than just me saying that, like, I could see that happens a lot and you go, yeah, it makes sense. Is there any studies on that or anything around generics? And
I think the tough thing is just because most of these drugs, when we're talking about we're talking about tablets, which typically are taken once a day. And if anyone knows, everyone is the worst patient. I'm the worst patient. For me to take one drug every day, it just doesn't happen, if I'm being honest. And so that's one of the nuances that when you have these conversations to be like, yeah, but are you taking it every day? And everyone's, oh yeah, no problem. Everyone's the perfect patient when they talk about it.
yeah,
I will say there's an interesting class, and we saw this. If you're familiar with the drug Synthroid, it's been around a long time. It's for a thyroid disorder. It's just literally replacing a hormone that you don't have enough of. So it is the one class that I would say a lot of members want the brand and they don't want the generic. And the whole reason they are like that is because this is a place where you're replacing a hormone. So a member can actually feel if they're feeling good or if they're feeling bad, like literally the day they're taking it. And so it's the
Mm.
one class where you see this pushback where they're like, I don't want the generic. On the flip side, if they move to the generic and they took it for a month, they actually could increase their dose and get them feeling the exact same, but they don't want to wait that time. And
Mm.
because it directly impacts their metabolism and how they feel and how they sleep, it's the one class where we have this constant. So if you talk to any pharmacist, they would just roll their eyes every time you have to talk about Synthroid because of how big of a deal this is. So that's one class where you see that, but I would say that's kind of a one-off situation. But it's definitely the one class we talk about brands versus generics more than anything.
Interesting. Going back to this theme of what decisions are we making because of dollars and what decisions are we making because of clinical outcomes, it feels like prior authorization might be one that leans more dollars, but it seems like step therapy actually leads more clinical, where outside of the, like you said, 0.001%, like everybody should be doing this because it's going to be cheaper for them. It's going to be cheaper for the plan, and the clinical outcomes are going to be exactly the same. So we should feel good about that one.
Totally agree. And I think too, you hear some groups talk about like dispenses written policies. Okay, if there is a brand name drug that has a exact generic available, if I'm a plan sponsor, I can say, hey, remember, you can get the brand, but the plan is only paying for the generic. So it alleviates we're not going to cancel access, but we'll give you access, but we're only paying for what the generic is. And so it's a unique way where you can say, we're still prioritizing generics, but if you want it, member, you can pay for it. So that's another similar to a step therapy that we can do.
And what do you call that type of plan?
Call it dispenses written penalties. So the member says, no, I don't want the generic, I want the brand. We're like, well, you can have it, but the plan's not going to pay for it. So they'll reimburse based on the generic cost, but member, you are full out of pocket for that cost. And so it's a way to, again, prioritize generics and make sure that those are being first to try.
And I assume there's some kind of appeal process for that, where if somebody does take the generic and it doesn't work or they have a bad outcome, they can get the brand at that price. I imagine there's some workaround in there.
There is. So they have medical necessity prior authorizations. And I think the biggest thing for both employers and for members, it's you can't just say that it doesn't work. You have to provide documentation. And I think that's the biggest thing. Yes, there are all kinds of pathways to say if medically you need this, but medical need is not just your doctor saying you need this. You have to show, okay, you actually have an allergy to it, or there's documented failure of this therapy. And so that's where it becomes a little more nuanced. And I think people just think if my doctor says that I need this, that's enough. And that's just not the space we're in today, especially where costs are.
Are there any other clinical management programs besides prior auth and step therapy that are worth talking about?
I think the bigger ones that we see right now, I think quantity limits sounds very simple. And I think some people are like, well, why would I want that? Like, why would I want to say for this drug, you can only get 30 pills? And I think it seems like a strategy that's not very important, but I have literally seen cases where a pharmacy is dispensing some injectable and they actually only hit 600 injectables and it goes out the door and it's billed for $600,000. And so just simple things like that are just, you may take it for granted, but it will protect you because again, there are a lot of human errors that happen and there's billing mistakes that happen. And I've literally seen a $600,000 charge that should have been a $1,000 charge just because they put 600 instead of one. So there's things like that I think are nice to haves that people don't think about. And then I think the other clinical strategies we see is I don't know if it's a clinical strategy, but it's the sole concept of biosimilars, so generics in the specialty space. I think those have grown over the last few years, and that's helped, I think, create transparency around the rebate issues, but also it's really highlighted, was my PBM really building a formulary around rebates, or were they pushing the lowest net cost? And at the end of the day, I want to get a lowest net cost, but I want you to show me the financials around it. And I think that's been the benefit we've seen with the biosimilar conversations in the last 2 years.
So is a biosimilar exactly the same thing? Is a specialty drug and a biosimilar exactly the same thing as a brand drug and a generic drug? Or is there a difference?
There's definitely a difference. That's why I try to keep it simple and call them generics. But if you think of like a tablet, it's literally just a chemical with fillers, right? And dyes. So exactly the same thing outside of some of the fillers. More of your specialty drugs, when we get into biosimilars, those are actually like for simple terms, grown in a petri dish. And yes, they're similar, but they're still different. And so that's why you can have biosimilars that, depending on how they're approved through the FDA, can actually be changed at the point of sale. And then you have some that can't. And so there's definitely some differences there. But by and large, and what we've seen in the market, they behave the same way. We're getting the same outcomes, but technically they are not exactly the same. And that sometimes can be difficult.
So if we're trying to think of how we get good clinical outcomes for our people, we just said a couple minutes ago that we can feel pretty good with step therapy because the drugs are the same. 0.001% of the people are going to have some kind of reaction and we can quickly move them to a brand. Do we feel the same way about biosimilars, or is there a different nuance that we have to think about when it comes to how we think about a biosimilar strategy in the plan?
Yeah, I think probably 6 or 7 years ago, we were really concerned, and this was more focused on the provider network, where providers are like, we're not sure if biosimilars are going to be the same. I'm not sure if we're going to get the same outcomes. I think if you fast forward to the last 24 months, you saw CVS, for example, moved everyone off of Humira to the biosimilar, and they saw 99% market adoption with I never had any cases where I saw concern. Now, is there going to be some issues somewhere? Probably, but I think that level of market shift helped providers get comfortable with biosimilars having the same outcome. So I think that's fundamentally changed. And now we're in a different place where everyone is very confident with biosimilars and they're driving value both on the cost side and for outcomes.
Would step therapy plans today include biosimilar use before getting the specialty drug, or is that a different type of program that
A
we would
little
need to put in
different.
place?
Yeah. And this highlights the issue with rebates, right? And what we saw the last 24 months is we saw some PBMs that converted very quickly to biosimilars and excluded Humira off the formulary. And then you saw some that said, hey, we're going to offer it at parity. And the reason they were offering it was parity is because if they kicked Humira off the formulary, again, they lost rebates, but the maker of Humira actually has a couple more products, Skyrizi and Rinvoq, which we've all heard on TV. Their way they negotiated the rebates are like, well, if you kick off Humira, we're not going to pay rebates on Skyrizi or Rinvoq. So some PBMs, just the way they negotiated, they're like, we can't do that. So they kind of offered them at parity. Now, I think you've seen them come to the table and try to renegotiate that, but that's why you saw some groups move 2 years ago, and you didn't see some groups move till this year. And it was this whole way of how they negotiate these rebates and really attached it to multiple products. And so that's the complexity I think that we've seen. But I think you're going to see more and more of a push on the direct contracting side with rebates where they're not allowing manufacturers to kind of spread that value across different products. And so I think we'll see that fundamentally change. But that's been one of the issues, I think, with how fast certain PBMs move in the market.
Interesting. Interesting. There's so much that happens behind the scenes and all the games that get played. So where does mail order come into all of this?
Yeah. So I think mail order, not a new strategy. I think 5, 10 years ago, you had a lot of groups that were saying, hey, we're going to require mail order just because they could get a better discount. So the unit cost economics just on how they were buying the drug were better. I think you've seen over time those unit costs become very similar to the retail network strategy. So what did we see over the last 5 years? You saw less focus on mail order. And I would say the majority of plans offer just on a voluntary basis. If you wanted this, it's more of convenience at this point. I think what we're seeing change, and again, this is just Matt talking, but as the retail networks change, right? Walgreens is going to have less stores, CVS is going to have less stores. You're starting to see Amazon, you've seen Mark Cuban. There may be a little bit of a resurgence of plans going back to mail order as a strategy. One, because the economics are really good. And two, and I hate to say this because I'm a pharmacist, I worked in multiple retail locations, but the member experience at a retail pharmacy is very difficult. And I have asked this question all the time. I'm like, would you pay more if you never had to go to a retail pharmacy ever again? And most people shake their head yes every single time. So I
Yeah.
think you're going to see a resurgence of how do we get more of this mail order strategy or this direct to consumer strategy with the Amazons of the world? I think that's going to grow.
So did I hear you say that there isn't savings with mail order anymore? Like the price kind of is parity with the facility?
Yeah, I'd say historically there was a huge opportunity, and there's going to be some more complexity there. We have some mail orders that'll actually contract an acquisition cost, and there's a huge opportunity there. But if we think of the legacy discounts, a lot of plans today can get the same discount if they do a retail 90 strategy. So just putting maintenance medications at retail from a 90-day supply versus mail order. But there's still opportunity there, just depending on how you're pricing that. But I'd say a lot of plans have gone away from that just because they were like, if I can get them the same price and they don't have to do mail order, does someone want to go to the retail pharmacy? And so we had a lot of groups kind of transition there.
Yeah. Interesting. I did not realize that the prices had increased that much.
Yeah.
You've mentioned rebates, I don't know, 100 times so far here. And I know that is a big driver in decisions, but I also know that the market is shifting a little bit. And so let's break down rebates. I guess maybe first explain a little bit again what they are, and then what do the PBMs do with them?
So that's the black box, but we'll start. I think we talked about the formulary strategy. So at a high level, like PBMs negotiate drug prices with manufacturers for formulary placement. And a lot of that negotiation is around what's the rebate being offered for a lot of those brand drugs. In simple terms, like I always say, if you want a good example of like how we buy drugs where there's a rebate involved, if I was selling you a head of lettuce and it was $20 and I offered you an $18 rebate to give you $18 back 6 months from now, so your net cost was $2, do you still want to buy lettuce from me? And I think that's like everyone would say no. Like, why would I ever buy anything like that? But that's exactly how we buy drugs today in the current supply chain. So just those type of economics are very difficult. I think on the other side, PBMs have these huge scale number of lives. And so they have created these huge subsidiary companies to have those negotiations. And so obviously there's a lot of rebate dollars. And I wish I had the number of rebate dollars. It's in the billions that flow through every year. But essentially they're negotiating that at the highest level, and there's fees that are coming out of that. There's administrative fees, there's data fees, we don't even know what those are for. And then outside of that, a lot of those are being passed through to the employer. And I think that's where, from a contracting perspective, from an auditability perspective, plans are really digging in right now. And some of that's coming from the federal level as well, is just really wanting to understand true net cost. But if you think of any plan today, if you're spending $1 million on drugs, there's a high likelihood that it's generating somewhere between $400,000 and $500,000 of rebates. And so, are those rebates coming back to the plan? Some situations, no. In others, you're getting closer there. But that's what started this whole conversation. Like, we have a drug price problem. This whole economics of the rebates is definitely driving an issue. And I think historically, what we've seen too is, and this is where it's fundamentally changing to your question, is we've seen 10, 15% increases year over year in the rebates being available to plan sponsors. And that is definitely plateauing. I think some of it's because of the legislation that's happening, but we're also seeing manufacturers, even in 2026, we saw 26 products that manufacturers actually moved away from high cost, high rebate to low cost, no rebate. And we think that's going to double next year. So the market's definitely shifting away from rebates, which I think is good. Less money out the door. Employers aren't shelling that out, hoping to get it back in the rears. And so I think that's some of the market shifts we're seeing. And biosimilars have played a part in that as well.
Yeah. So let's talk a little bit about that. I have a couple more questions on rebates, but let's just keep that progression going. So, what is the difference then between a rebate model and a lowest cost at point of sale model? And I guess I've heard this term. This is a question that I have. Is the lowest cost at point of sale, is that a different PBM model, or is that just a different formulary model, or is that something that's coming from the manufacturer? Like, help me understand what that is versus the traditional rebate model.
Yeah. So I think what you're referring to is like point of sale rebates. Is that kind of where you're going?
I maybe, I don't know. This is where we've hit the edge
Totally
of
fair.
my knowledge.
I'll just throw an example. Like, so
Yeah.
Humira is like the prime example for biosimilars, right? This product on a claims basis was probably, most plans were probably paying $8,000 per script. Now, depending on your PBM contract, you were probably getting $4,000 back in terms of a rebate that was paid 6 months down the road, right? So your net cost was $4,000. Well, then all of a sudden, the biosimilar comes out, and we can use Mark Cuban. He has Yusimry. It's a really low cost biosimilar. That drug's coming out at $800 per script. And so if you're a plan sponsor, you're like, why would I do 4,000 versus 800? I'm choosing 800 all day long. So I think that's the whole concept of driving the lowest net cost. Now, we talked previously, okay, I was in this Humira model. I don't want that model, but if I get away from that model, depending on how the PBM negotiated with the manufacturer, I might lose even more rebates than just what Humira is driving. So that's the complexity. But if you think of the point of sale, $8,000, if you think of point of sale for 800 with Usimrate, then you start thinking about your plan design. For my members, it's actually better. If I'm on a 30% coinsurance, like I want that all day long. And actually, I think I have some risk if I'm charging my members 8,000 bucks, a 30% coinsurance on 8,000 bucks. So I think those are
Yeah,
kind of
but
the
then I'm getting
dynamics
a
that made it.
$4,000 rebate.
Yeah, yeah.
Yeah.
So that's the one you're like, let's pause the brakes. Like, how do we shift this model? And I think that's where a lot of plan sponsors are today is this was great as costs were going up, but trend is where like we need to make better decisions. And then you compound that with a lot of the focus on fiduciary responsibility that we see that is directly focused on the pharmacy benefit. And so that low net cost option is looking really good right now, especially from just a dollars and cents perspective, but also just that fiduciary concerns that we see.
What about rebate addiction? With the companies that you talk to out there, are you seeing them struggle to move away from these rebates? Because what I have seen is that they have their pool of money to manage the health plan and they spend that money on the full price of the drug. And then, like you said, 6 or 8 months later, they're going to get these rebate checks back. And it's, oh, we have found money now. We can go do something else with this money. And I've seen employers struggle to, when you talk about this concept of getting rid of the rebates, they're like, yeah, but I use those rebate dollars. How are you talking employers through that to wean them off the addiction of rebates?
And it's where the industry's been for the last 10, 15 years, and it's grown so much year over year. And so I think what you have to remember is when you're looking at, we could use an RFP, like, yes, rebates are going up. Like, rebates probably aren't going to go away in the next year or two. So you have to use them where you need it strategically, right? Like, we've seen them be very beneficial in GLP-1s when you get transparency there. We see them be very beneficial in certain drug classes. But I think what's happened is like we've been so focused on rebates, we're not looking at the other kind of KPIs we want to look at. It's okay, we negotiated for great rebates the last year, 2 years, 3 years. What was our trend? What was our trend over the last 3 years? And a lot of plans will be like, we had smashing rebates, but our trend was 25%. And like, you paid for those rebates because at the end of the day, when you want a rebate, you're paying for a higher cost drug. And so that's
Yeah.
just the economics where groups are like, yeah, that doesn't make sense. Like I have the best rebates in the industry, but my trend's at 25%. I'm like, let's start talking about what that might look like because what we're looking for is PMPM management and like ongoing performance. And so that's where I think groups start to get a little disingenuous where they're like, well, we've been prioritizing rebates, but no one's asking what our trend is. And I think that's the question is like, what has your trend been? And is it beating the standard trend that we're seeing of 12%, something like that? And I think that's where a lot of groups that I work with, it's okay, what are we doing today to make sure that we are performing better than the national trend? We know there's going to be new people that start drugs. We know inflation is going to happen, but what are the things that are moving the needle to make sure we are beating the national trend? And I think that's the strategy that we're moving to.
Yeah, it's like I was watching like a Dave Ramsey video on like financial advice, and somebody called in and was trying to, they were like spending more to maximize tax deductions. And he was like, that's not how this works. You're just spending more money. You're spending $1,000 to save $250. Just stop spending the money, save the actual money. And I feel like that's what I just heard you say.
And it's hard for groups too, because if I'm a PBM, I'm going to give you a smashing rebate guarantee. Well, how do I make sure I hit that guarantee? I just got to make sure I have enough utilization. So as long as utilization continues to go up, I'm probably pretty confident that I can hit that guarantee. And I think where we're at in cost is we are really focused now on controlling the utilization, right? That's how you start to lower your PMPM cost is really managing utilization. And that's fundamental change that we've seen in the marketplace. But I always try to talk to groups like, you can hit any rebate guarantee you want if you open up the floodgates and your utilization goes up. So let's start talking about what are the other things. And so I think what you're seeing to help with that is you're starting to see some PBMs start to say, we had been contracting for a discount guarantee and a rebate guarantee. And so you started to see some of these groups start to come out. And again, these are still in flight, but you've got some groups that are saying, we actually want a PMPM guarantee. We think maybe that brings some of this drug mix management component into what we want from our PBM partner going forward instead of this rebate guarantee, which for them to hit it, they're going to have a ton of utilization. So I think there's things that are changing that are kind of helping with that. But it is definitely a conversation where groups need to go back and be like, what has our trend been over the last year, 2 years, 3 years, and start thinking about it differently for sure.
Yeah. One quick question, and then I want to talk about the new models of PBMs that are emerging too. But if we're running a fully insured plan, we're seeing the costs come through. We're getting our reports on our medical and our pharmacy spend. How much or how little are they taking into account the rebates that they're getting on the back end? The
Carrier's definitely getting them, and the employer in a fully insured environment is definitely not seeing those, but it's large numbers. When we look at groups that are you thinking about going self-funded and you look at if you're spending $1 million on pharmacy, there's a high likelihood, and again, your utilization drives that, but there's $250,000, $300,000 in rebates that are staying with the carrier as part of their overarching strategy. And it's hard to say like how those rebate dollars impact your premium on a fully insured basis, because I would argue most of those premiums always go up every year. So I would argue they're probably not getting taken into account, but that's just me being a skeptic, but educated skeptic maybe.
Yeah. And I just want to point that out because I think that's something that's often missed in this conversation of, oh, our loss ratio was 95% last year or 100%, and the carrier wants it to be at 85%. So yeah, of course our costs are going to go up. And it's, yeah, except that they also made several $100,000 in rebates that they didn't disclose. So it really wasn't what they're showing you. It was, they actually did fine. This is why carrier loss ratios across the carrier book of business can be bad and they still make billions of dollars in profit every year. They are finding ways to make money.
Exactly.
Anyway, just wanted to make that point. So let's talk before we wrap here just about the new model of PBMs that are emerging. Because right now you've still got whatever it is, 80, 90% of the market running through the major PBMs that are now all either the PBMs own the carriers or the carriers own the PBMs. So if you're working with one of the major carriers and you're working with their PBM, like that's where they're funneling all that money and they're making a lot of money on the pharmacy side. But there's this like new class that's emerging. Can you talk to what that is and how you're looking at that and maybe helping clients think about when it makes sense to pull the trigger?
Yeah. And I think I mentioned earlier, there's north of 80 different pharmacy benefit managers in the market now. And I think some of that is just because of where the sheer costs have gone. So they're looking for alternative models. And so I think a lot of the PBMs we see in more of this mid-market space are offering some uniqueness around either transparency to cost, so getting better visibility into your rebates. They're offering a different level of member engagement. I think we talked a little bit about that drug mix management. And so if we use an example, I always say, that's great. You're giving me a 90% discount big three PBM. Am I okay with an 80% discount if I have a PBM that's taking that 80% discount on a $10 drug instead of a $10,000 drug? Discounts are great, but is it the right drug where I'm getting the best deal? So I think that's one component. And I think too, the other one is flexibility. So we want groups that are saying, hey, I know costs are going to go up. I want to be able to partner with a Mark Cuban. I want to be able to go after some of the patient assistance program opportunities or some of the income focused opportunities when we think of high cost specialty. I think I'm going to need that strategy. And so why they're getting that flexibility is a lot of the mid market are taking some stances around, we're not going to own our dispensing assets. So we're not going to own our mail order or specialty. And so we're going to have some better prior authorization management capabilities there. But I think the bigger thing is going to be around stronger focus on drug mix management, flexibility for plan sponsors around alternative models. So could they offer a PM guarantee? Yes. And so I think why you're seeing a lot of groups move this direction is they've been at the big three and their trend hasn't changed over the last 3, 5, 6 years. And so I think that's where we're seeing a lot of groups start to make this transition and realize a lot of savings because they're getting better visibility into costs, which is key. But they're also getting flexibility to say, hey, I know I'm going to have to continue to pull levers over time. And they're offering more levers. And that's why we're seeing a definite focus there.
And I just, for clarity, you've said PM a few times. That's per member per month. So,
yes. Sorry, acronyms.
I always try to catch the acronyms. For anyone who's listening out there, is what's PM? It's per member per month. Oftentimes when we're talking about benefits, whether it's on the medical side or the pharmacy side, we are breaking the cost down into a per member. That's per person on the plan, not just your employees, but every belly button or individual on the plan per month. And so you can standardize the cost and you can see, okay, what am I paying per member? And is that number the right number compared to a benchmark versus your overall population? It can be hard to tell. So I just want to clarify what that means. Back to these new models, some of them, I heard you say the benefit is on better clinical management. And so if we've got the legacy PBMs showing really well on a spreadsheet because they're just pounding rebate dollars down your throat, And then we've got these others that maybe don't have the rebates. And so if you look at them on a spreadsheet, they're not as appealing, but there's this clinical management side. How should an employer be vetting that? How much should we be relying on the spreadsheet versus how much should we be relying on maybe other factors, promises, guarantees that we're getting from these emerging markets?
Yeah, I think one is looking at just and thinking about it from a go forward performance perspective. So starting to think about, okay, PBM, what is your book of business trend? Will you share it? What does that look like? I think the other thing is you're starting to see to compete in this space. And to your point, they cannot buy as good as the big three. Like those guys will always win on the rebate side. But I think what they're also seeing in this mid market is what I talked through. They're saying, hey, we're going to offer a PM guarantee and we're going to go at risk for it. So whether that's all of our administrative fees are going to go at risk to make sure that we're managing your plan better, and you can measure that at the PM level, or we're starting to see some groups start to offer clinical savings guarantees. And so I like to caveat that, like any guarantee, there are caveats. So I think you want to spend time understanding that even within a PM guarantee, like what is included, what is excluded. Am I okay with that? But I think that's the level that groups are starting to look at is, okay, I see a really good rebate opportunity. I know my trend is 15 to 20% year over year in that model. Well, what do these other models look like? And okay, if they're offering me a PM guarantee, I kind of like the fact that they're going at risk. And if they miss that PM guarantee, they don't make any money. Also, do I get better visibility into costs? And then am I comfortable with the caveats? And so I think that's where you need to start spending time because it is, to your point, it's very difficult to put those side by side and say this is apples to apples because it's just a different model. And so we always have some groups where they're saying, okay, here's a traditional PBM RFP, here's a non-traditional. Let's see what those look like so we can actually see what side by side might look like. And again, asking questions around what's your trend management strategy? What does it look like for a book of business? Those types of things are very important because at the end of the day, we don't want to choose a PBM just based on historical claims because we know what happens in pharmacy is everything's going to change. Costs are going to go up. And so we're really looking for someone that's going to perform over time.
Yeah. And I just want to plug that again for people out there because it's easiest to look at a spreadsheet. And I think that's often what drives these decisions. And it's hard to get a committee of business executives who do not do this stuff every day to sit around and understand the clinical impacts and what's going on with trend across broader book of business and PM guarantees. It's just like very quickly, you're like, whew, holy cow, my eyes are rolling back in my head and we're just going to go with the lowest cost. But I do think this is one where get a good consultant and have them walk you through it. But you got to spend a little bit more time understanding because these dollars are so expensive and they are trending up faster than medical trends. So this is the area that you want to slow down and tease apart.
Totally agree.
Yeah. Matt, we're already over time. I could ask you another hour's worth of questions, but I won't. I appreciate you coming on here. And I think we did a fairly decent job on a very complex topic of easing into what the different components are. I will say, as I've said in other episodes before to anybody listening, if you do have questions about this stuff, if you want to go deeper on this, reach out to me. Happy to talk about this myself. Happy to put you in touch with Matt or our pharmacy team, because I know that these are tricky situations to navigate. So definitely don't be shy in reaching out with questions if you do have them. Matt, anything that we didn't hit on that you want to say or any final thoughts to share with the audience before breaking?
No, I think we went through it pretty well. I think I always, when I'm working with groups, it's okay. What are the big pillars that we want to make sure we're addressing? I think one, visibility into net cost is huge. I'm not going to say transparency. Everyone says that, but like, how do I get visibility in my net cost? I can't make good decisions without that. Two, flexibility is going to be key. We know things are going to change. So what type of flexibility am I going to have as on the formulary side, on the program side? And then I think the bigger thing is like, how is my PBM partner impacting my drug mix? So are they engaging my members? Are they offering tools? What are those things? Because there's a massive opportunity in making sure that the right member is on the right drug at the right pharmacy. And so those are key things that I think of in terms of pillars for pharmacy strategy all groups need to be thinking about.
Love it. Matt, thank you for coming on the show. Everybody who is out there, appreciate you listening and good luck because this is a tough topic and just wish you the best.
Awesome. Thank you.
Hey folks, one last thing before you go. If you enjoyed the episode, make sure to hit subscribe so you can stay up to date with future guests. That's it. Thanks for coming. Go make the most of your business and the people in it.